Ladies and gentlemen, thank you for standing by, and welcome to the CDC Perinatal Quality Collaboratives webinar. During the presentation, all participants will be in a listen-only mode. Afterwards, we will conduct a question-and-answer session. At that time, if you have a question, please press the star followed by the 1 on your telephone. You may also enter questions at any time throughout the webinar by using the chat feature located in the lower left-hand corner of your screen. If you need to reach an operator at any time, please press star 0. As a reminder, this conference is being recorded. Thursday, March 24th, 2016. I would now like to turn the conference over to Dr. Henderson. Go ahead, Dr. Henderson.
Good afternoon, everyone. My name is Jaquiba Henderson, and I lead the activities in support of state-based perinatal quality collaboratives in the Division of Reproductive Health here at CDC. And I'd like to welcome you to today's presentation for the CDC Perinatal Quality Collaboratives webinar series. Today's webcast will be an informative discussion of the value of using administrative data for perinatal quality improvement initiatives, its strengths and weaknesses, and how it can help focus limited quality improvement resources. At the end of the presentation, you'll have the opportunity to ask questions and participate in the discussion with the presenters. You may also submit questions via the ReadyTalk chat function as mentioned by the operator throughout the presentation. A recording of this webinar will be archived on our webpage at www.cdc.gov/reproductive health/maternal infant health/PQC. Handouts were made available with your reminder email after registration for the webinar, and will also be made available again to registrants in a follow-up communication after the webinar. Our presenters for today are Janet Murray and Drs. Barton Statt and Martin McCaffrey. Janet Murray is the president of the National Perinatal Information Center Quality Analytics Services in Providence, Rhode Island. The National Perinatal Information Center, also known as NPIC, is a membership organization of delivery hospitals from around the U.S. She's worked with NPIC for 29 years and assumed the role of president in 2007, where she is responsible for the overall operational and strategic management of the organization. Member hospitals provide their administrative data set to NPIC quarterly, and NPIC then provides comparative benchmarking reports back to them. The reports profile their perinatal volume, utilization, acuity, and quality in comparison to their peer subgroup and the database as a whole. They also design special ad hoc reports on perinatal hot topics and work with private and public organizations to support the analysis of their perinatal data sets to turn data into actionable information. Dr. Barton Statt is a consultant for obstetrics and maternal fetal medicine to the Air Force Surgeon General and is chair of the Defense Health Agency Perinatal Advisory Group. In addition, he has been a leader in patient safety and obstetrics. He's coordinated quality improvement activities for 12 Air Force hospitals all across the world and was a main author for the Defense Healthcare Agency 2015 Perinatal Safety Initiative and provided strategic oversight to education and rollout of the initiative for over 50 hospitals and affecting 50,000 births annually. And lastly, Dr. Martin McCaffrey is a neonatologist and professor of pediatrics in the Division of Neonatal Perinatal Medicine at the University of North Carolina, Chapel Hill. He retired as a captain from the U.S. Navy Medical Corps in 2006 after 20 years of service, where he served as the director of the neonatal intensive care at the Naval Center in San Diego and as the Navy Surgeon General Specialty Leader for Neonatology. He is a member of the National Perinatal Information Center Board of Directors and is the director of the North Carolina Perinatal Quality Collaborative, whose mission is to make North Carolina the best place to be born. I will now turn the presentation over to Janet Murray.
Thank you, Dr. Henderson. Dr. McCaffrey and Dr. Statt and I greatly appreciate this opportunity to talk to your Perinatal Quality Collaborative Network participants. What we want to do today is spend some time talking about the value of the administrative data. We have no relationships to disclose. The objectives to this webinar, as we've discussed or we've outlined in the documents that were sent out to the participants, is to talk about the administrative data set, to give you an overview of using this green data set to complement your statewide initiatives. We want to provide some analyses of some of the current hot topics. We've selected 2 maternal and 2 neonatal hot topics that we want to share with you using analyses from the administrative data set. And then Dr. Stat is going to share an application of a multi-hospital quality improvement initiative that was prompted by the comparative data set, comparative metrics that were given to the Defense Health Agency using their administrative data set. Before we get started with the discussion of the administrative data set, Dr. McCaffrey is going to talk a little bit about the challenges for the collaborative, since he's well familiar with those challenges given his role as chair of the North Carolina Perinatal Quality Collaborative. Dr. McCaffrey?
Thank you, Janet. I'll actually speak to y'all in sort of putting on 2 different hats. My previous life as a military officer and a Navy doctor, I was the director of the Perinatal Advisory Board for the United States Navy, and we had oversight of 23 hospitals at that point and were charged with improving quality across those 23 hospitals worldwide. And I'd like to talk to you just briefly as well about the new epic in my life, which is directing the Perinatal Quality Collaborative of North Carolina, or PICNIC. In the prior life that I lived with the Navy, and the Colonel will speak to this as well, we were faced with lots of challenges related to trying to assess and analyze the accuracy and the quality of the care that we were delivering in multiple military facilities across the world. And in trying to determine how best to do that, it became clear that one source that we had that we could rely upon to try and make some sense about things and to try and benchmark things and determine where the level and quality of care was at was through the administrative data set. As a member of the United States Navy's Perinatal Advisory Board, we also participated at that point with the DoD-wide Perinatal Advisory Group, which the Colonel now heads, and he can speak more a bit to issues today. But when we scanned around and tried to find places that we could use this administrative data, it became clear that we needed an organization, or to look for organizations that were capable in looking at this data, in analyzing this data, in cleaning this data. And I will say that when we started this process early on in the Navy, we did go ahead and work with the group that we're talking about today. Janet works with, NPIC. There are other groups that do this as well, but what became clear as we worked with this data is that it was not clean data, and it was data that had some clear inherent problems in it related to the correctness and the accuracy of coding. So when we did finally decide that we were going to use this set, what it required was several years of sitting down with individual facilities and walking through what their process measures were for actually coding. And what we found were lots of issues related to birth trauma and other things that weren't truly birth trauma. And it was several years of work which really allowed us to clear this data set up, which got us to the point where we could really think about doing actual quality improvement projects related to advancing newborn care and related to maternal safety. Fast forward that to where I am now, and as the director of the Perinatal Quality Collaborative of North Carolina, we're fortunate and we're grateful to the CDC to have the opportunity to be part of a group of 5 other states, 6 total right now, and maybe there'll be more in the future, who knows, Kiba, that are part of the CDC work, but there are many collaborators out there doing fantastic work, and many of them at the state level. What we all recognize as we move forward and try and improve the state of perinatal care in our states is that people are overwhelmed by a number of things. They're overwhelmed by changes in the care environment. They're overwhelmed by education and trainee changes in training environments. They're overwhelmed by what's happening in terms of intensity of illness. They're overwhelmed by EHRs and a multitude of other factors which come into play, certainly on the inpatient care side of things, but also obviously on the outpatient care side. This all makes trying to really get people to sit down and look at the work that they're doing and collect data very, very challenging. And even though we may have great projects that we want to roll out, areas of work that we know we have to be engaged in and improve upon, we also have realized that it's limited in the amount of time that we can ask people to dedicate to collecting extra data. And what has become clear to us, and it refers back to my military days, is we have this huge administrative data set which is already being collected and sent off and being analyzed probably at some level, possibly within your own state, certainly being looked at possibly somewhere within your own hospital. And if we could use this data and clean this data, could it be good enough to, number one, like I did in my prior Navy days, identify areas that might be potentially problematic and invite the need for quality improvement measures, but could it also, number two, be valuable enough and give enough detail to try and direct some of the actual quality improvement work that we are currently doing? I think the fantastic opportunity is to take this administrative data set, to combine it with other data sets that are administrative and already out there, which might include birth certificate data, which might include state-level private payer charge data and case data, or Medicare, Medicaid data, and bring those all together into one location where you would have a huge administrative data set that could actually give you lots of feedback on what's going on, many of it patient-level focused data, and help to drive quality improvement. I think Janet has two of my slides there, and I'm going to ask her to make sure we're advanced to my last pictorial slide there. And I think this is what happens to us at the state level, certainly, and I think a lot of us anywhere doing quality improvement work. What we come up with is an area of care that we think we need to work in. We know what the processes and the outcomes are that we want to track, and we ask people to start doing that. And we start asking for data that isn't necessarily readily available or extractable from EHRs currently, maybe in the future it will be, and it means that people have to hand collect and enter data to support the work that we're doing. I think where we want to get to, as far as certainly our collaborative in North Carolina, and I think this is what we've expressed with all the collaboratives that we have ever met with, and they've expressed it as well, is we need to get to the point where data is readily available, it's easy, it's manageable, it's the limited data set that we need to support the work. And what we all want to do is get down to the work of actually improving care. And I think it's absolutely positively true that administrative data, if we could make it cleaner and if we would open our minds to thinking about it and trying to use it, that it would be an incredible help into moving us towards the place where folks at the facility level and at the bedside level can focus on improving the care and focus less on collecting data. Thanks, Janet.
Thank you, Dr. McCaffrey. Just to, before we actually get into the merits and some of the challenges of using the administrative data set, I wanted to tell you a little bit about NPIC, follow up on Dr. Henderson's comments. We are organized as a nonprofit. We're located in Providence, Rhode Island, and we're incorporated in 1985, so 30 years ago. Our mission is to improve perinatal health through the comparative data analysis, program evaluation, health services research, and professional continuing education. Obviously today we're going to focus on comparative data analysis. We are developers of quality improvement reports for our members and for our contracts so that they have actionable information. Currently, our data partners include those that the developers of the Adverse Outcome Index, those folks that are at the Beth Israel Deaconess Hospital in Boston. Certainly we're going to talk about the Defense Health Agency partnership, Research Triangle International in North Carolina, and Ariadne Labs in Boston, Massachusetts. So when you think, as Dr. McCaffrey was talking about, you think of what are the data sources for your quality improvement activities. I think the initial thought is to go for primary data collection, either abstracting medical record data, certainly electronic health record data. Every hospital is in a different stage of maturity with regard to EHRs, so sometimes that can be a challenge. Customized perinatal data sets. We know from our members a lot of hospitals have data sets within labor and delivery that they can pull data out, again, either electronically or sometimes manually abstracted. And then project-specific data that is really focused on the particular project that you're involved in. You may set up a data collection tool that hospitals can do data entry with for the variables that you're looking for your project. What we really want to talk about today is secondary data sources. The administrative data set is our focus. It's sometimes called the hospital discharge data, UBO4 data, billing data. So it has a number of different names. Some of you on the call may be fairly familiar with this data set, but I suspect many of you are not. The other secondary data set is certainly the birth certificates data. We'll talk a little bit more about that as we get towards the end of our presentation, but we're really primarily focusing on the administrative data set. And why are we doing that? We're doing that because it is an industry-wide data set. Every patient who is discharged from the hospital has a record in this data set. Most of the data elements, and we're going to show you most of those in a minute, but most of the data elements are fairly standard, and that's really driven by CMS. The data set, because it is used for a billing data set, was initially put forth by CMS for payment of Medicare bills. But obviously this data set is used for all patients, so all of the variables that are included in this data set are fairly standard across all of the data sets that are particular to a specific state and payer. The elements, because they are used for billing of inpatient hospital services and have clinical and financial detail, they require a fair amount of accuracy. So the fact that it's universal, it's complete with all discharges, and hopefully, as we're going to talk about, accurate, it makes it very relatively easy and inexpensive to analyze. The problem that we find in the perinatal community is that many clinicians are unfamiliar with this administrative data set, or they frequently will dismiss it as coded data. The dilemma is that this data set is being used by many external groups from external to your hospital. So they are doing these metrics, calculating different quality indicators. They are using this data set for the original population selection for your Joint Commission metrics. So there are a lot of, as I said, external factors, external groups who are using this data set. And so our feeling is that it's really important for those in the hospital, particularly the clinicians and the quality folks, to know what your data is saying about the quality of care at your institution. Our feeling is that sometimes you ignore this data set at your peril. Dr. Stat will talk a little bit about that in his remarks. So as I mentioned, this data set is often called the green data set. These comments and this quote comes from Dr. Jeffrey Gould, who is with the California Maternal and the California Perinatal Quality Collaborative. He mentioned this at a Massachusetts Neonatal Quality Forum in June of last year, and basically said what we are preaching here today is that building a hospital or a statewide culture of excellence, you need to minimize your data collection burden by using green data. That is data that is collected for another purpose that can be supportive of quality improvement activity. So we do see this as a data set that can complement what you are doing and reduce that data collection burden on your facility. State administrative data. This is all of the states, 47 actually to be specific, 47 states collect the administrative data set from all of their hospitals. 38 actually mandate its collection. So there's a very good chance that your particular state actually has this data available to you or available to the leadership in the Department of Health, the Hospital Association, the Maternal Child Health areas, Department of Statistics, each hospital. I mean, each state is a little bit unique, but basically you've got 47 states that are collecting this data. We find that the perinatal data, even though all discharges are included in this data set, it's a very large data set, it's patient-specific. The perinatal data can be easily isolated. You can do that by ICD-9 or ICD-10 codes, major diagnostic category, or diagnosis-related group. As we said, because the format is standard, it can be really relatively easy and inexpensive to analyze in terms of a statewide project. Reporting back selected metrics. When you start analyzing this data, we find that when you start reporting back to hospitals their data, whether it's a rate or numerator denominator for certain metrics, this often will pull the hospital and the clinicians into the conversation. They'll be interested in what the value of the data is. They'll want to talk about improving the data. They will often request that their cases that are making up the numerator for this particular rate, that they get information on those cases so they can drill down and audit their data. So clearly there's an opportunity for using the data for a statewide or regional quality improvement activity. And again, we find that the primary data collection that you will likely need for a specific engagement can supplement this administrative data set. I want to talk a little bit about the concerns for privacy and confidentiality. Obviously, this data, this is a very critical issue for this data because it is patient-specific. It will often contain not only patient identifiers, but hospital identifiers. So to the degree that it has to be protected under HIPAA guidelines, that's a very important conversation to have up front with the folks in your state that own this data set. What are their agreements with the hospitals in the state regarding the reporting of protected health information or even hospital identifiers? So that's really an important conversation to have for when you're creating and reporting your hospital-specific metrics. Are you going to encrypt or blind the hospitals? And is there someone who has the, if you're looking at patient identifiers that are encrypted, is there someone that has the crosswalk for that encryption? So when you give back to your hospital data around certain metrics, and again, numerator or denominators for those cases, can the hospital then go back and decrypt those cases, decrypt the identifiers, and drill down and audit their data? Because as Dr. McCaffrey said, it's really critical when you're looking at the quality of the data that you get an opportunity to look at the documentation by the providers and the coding by the coders, because that will tell you whether or not there is a disconnect there between the two. And if you are looking to improve the quality of this data set to be used for purposes of going forward and monitoring metrics for a QI project, you have to go through that activity first. You have to make sure that those that are engaged in looking at this data, the end users, have the level of confidence that the data is really accurately reflecting their institution. These are some of the state files that we've directly worked at. There are many others, but these are the ones where we've written conversion programs, and you can see we've highlighted the 6 CDC-supported perinatal quality collaboratives. We've given the acronyms for some of the state data sets. Some of you may know these by the acronyms. The New York data set is the SPARKS data set. The Florida data set is the ACA data set. Massachusetts is the CHIA data set, et cetera. Washington State is the CHARS data. So you may have heard some of these acronyms but not really understood that this was your administrative data set. Some of the variables that are included in the administrative data set, as we said, it's fairly standard across most data sets. The formats may be slightly different. Some of the components may be enhanced by certain data, by certain states. But basically, you have your hospital identifier. You've got a patient identifier, whether it's the actual medical record or something that's encrypted. You've got the demographic information. Again, a lot of this is HIPAA data, so depending on the agreements and how you're analyzing your data set, you may need to have a business associate agreement in place to actually look at some of these data variables. Patient billing number or unique ID, this is critical because you want to be able to track. The medical record number stays with the patient over time, whereas the unique ID for this particular episode will identify multiple inpatient stays. So this is important when you're looking at readmissions. It can be important for regional centers that want to look at antepartum admissions that come into the hospital, have an inpatient stay for a period of time, are discharged undelivered, but then come back to deliver. So this unique identifier will help you identify those separate episodes. Source of admission, is the baby or the mom a transfer in from another hospital? That's important. Did they come in as a routine admission? Discharge status. I think that's on your choice, but discharge status is, again, was the critical in our area is whether or not the mom was transferred out for care, or a baby, if you have a very low birth weight baby that's born at a level 1 facility and needs to be up transferred to a regional center, you can tell that baby was transferred. You can also, with other metrics in terms of admit date, discharge date, you can tell if that baby was discharged immediately on the day of birth or 2 to 3 days later, et cetera, et cetera. Diagnosis and procedure codes, again, this is all coded data, ICD-9 and now ICD-10 data. And this gives you the whole range of comorbidities and complications that occurred at the inpatient stay for this patient. Present on admission is going to allow you to determine whether or not certain conditions were present when the patient was admitted, and so that tells you, again, what occurred within the hospital versus what was brought into the hospital by the patient, a comorbidity or some sort of infection, et cetera. Physician identifier, the same thing. This is usually a number and not a name, but again, you have to look at the agreements, whether or not you would even disclose that information or drill down. We talked about the DRG codes. The CMS grouper is very often run against this data set, so there will be a DRG code on the patient's file as well as a subclass indicating risk of or level of acuity or risk of mortality. Total charges. Very often there'll be at least total charges. Some files have very, very detailed charges that go specific to ancillaries. So this is some of the, on the accommodation side, the detail that we at least like to get on our data files. Again, each state will differ, but some states will have even much more detail on the ancillary side. One of the things I want to point out is that on the newborn side, what's nice about having accommodation charges subdivided into routine care versus intermediate care or intensive care is that allows you to identify whether or not the baby was admitted to a special care area. So, and whether or not the baby spent time in an intermediate care bed, which is generally something like an observation bed or a feeder or grower bed, just so it's not at the most intense level. If you've got your intensive charges, that can tell you whether or not the baby was actually in an intensive care bed, and that's really very, very helpful. Perinatal variables that may be on some of the state files. This will vary from state to state, and most states will publish their layout and their record of the listing of all of the variables. Some will include birth weight, gestational age. Very few have APGAR 1 and 5. Mother-baby link. I think there are just a very few states that have the mother-baby link. Obviously, this is a really very nice variable to have if you can get it, because you can then look at the complications or the comorbidities on the maternal side and look at the outcomes for the baby. If you are doing a quality improvement project and you want to link the administrative data set or some of the variables from the administrative data set, very often we find that states will, or hospitals will be able to provide an Excel spreadsheet or a listing of mother's medical record numbers that link to the baby record. So you can actually, with a little bit of manipulation and programming, you can actually merge that data into the source file. So I want to show you some samples from using the administrative data set, and we did have one correction. I apologize. On the initial slide, we said we were going to look at PSI 17. We're actually going to look at unexpected newborn complications, which is an NQF measure. But these are the two maternal. We're going to talk about HR2 IQI33, which is primary cesarean delivery rate, uncomplicated, severe maternal morbidity, for which those of you that are involved with the AIM initiative, if you are an AIM state, you know that this is the metric that is being used for that AIM initiative. Unexpected newborn complications comes out of the California Maternal Quality Care Collaborative and is a very interesting metric that is getting a lot of attention. And then neonatal abstinence syndrome. This is certainly a very notable problem that has been growing over time. I'm sure most of your hospitals have been impacted by that. And so we want to talk with you a little bit about an analysis that we did, but then some of the complications with that. So the value of the comparative data, obviously you can look at your hospital over time. That's really important. You want to look at trends for certain metrics. One of the things that we always talk about is the fact that you may be looking at your birth trauma rate over the last 5 years, and it started at 25% and it's down to 10%, so you feel like you've made great improvement. But when you start looking at your data compared to a peer subgroup, all of a sudden you realize all of the other hospitals in your peer group are down at 2.5%. So that tells you that maybe that 10% has lots of room for improvement. So again, you always want to look at your data over time, and this data set can help you do that. But again, the value of looking at a peer group or a statewide average or a quality collaborative average just gives you much more information about possibly your outlier status and prompting you to drill down and look at, as I said, the provider documentation and the coding of the data. You want to start with, is there a disconnect between the provider documentation and the coding of the data, such that that metric is not really descriptive of what was the complication for that measure. Once you have that level of confidence that you're all on the same page with provider documentation and coding, then you can look at your metrics as a clean descriptor of the quality of care at your facility. Dr. Statt's going to talk a lot about initiating an educational opportunity with the clinicians and the coders. That's certainly a critical thing. It helps the value of this comparative data once, as Dr. McCaffrey was saying, when you look at a number of variables, it can help focus. Where do you want to spend your time? If you've got metrics that look reasonable and you're fairly comfortable, you may say, well, we're going to concentrate on those where we've got huge amounts of variability across the hospitals within our state. or where we feel like there's really opportunities to use our QI resources very effectively. Everybody is very limited in what they can spend their time and energy on. And as we said, if you're doing solely abstracted or primary data collection, you're missing an opportunity to use this green data that is already available to you. So I want to talk about the AHRQ, that's the Agency for Healthcare Research and Quality. They have 4 sets of quality indicators: prevention, inpatient quality, patient safety, and pediatric. Obviously, the pediatric set deals with the pediatric population, but the adult and perinatal goes across all of the other sets: prevention, inpatient, and patient safety. The software to run the metrics using the administrative data is publicly available, and the link is there on the slide. The IQI33, this measure, the denominator for this measure are cases that only include deliveries that are primary, obviously without a prior C-section, term, singleton, and vertex presentation. So the software identifies the denominator population. When you run your delivery cases for whatever period you're looking at, whether it be a quarter or a year or multiple years, you're only looking at those that are term, singleton, and vertex. Now this may sound very familiar to you, though, to those of you that are familiar with the Joint Commission PCO2 metric. The difference is that this IQI33 does not exclude multips, and that is because most of the administrative data sets do not include parity. So the numerator for this IQI33 metric are those cases from the denominator that are delivered by C-section. And I just want to show you a sample of a table, of an IQI33 table that you could create for your constituents at the state or the collaborative level. So here we've got the hospital data here. So this would be the hospital ADC, and then the statewide average. You could even, in the middle here, put a peer group, and the peer group could be academic, non-academic hospitals. It could be hospitals with a volume of greater than 2,500. It could be hospitals that are designated as only level 1 hospitals. It really, whatever the peer group is that you have determined that you want to, in fact, create for your hospitals. So here we've got the primary C-section, and then this is the section that identifies the IQI33 details, and it talks about where did we start with the deliveries, how many were excluded, what was our final denominator, and what was our numerator, therefore what was our rate using the AHRQ software. You can also pull out, if you so choose, the average length of stay and comparative charges. What we wanted to do here is give our hospitals back some information on how many cases in the numerator were actually had induction codes. Again, the induction codes are an ICD-9 code. There's a little bit of some issues around the ICD-10s with inductions, but basically the ICD-9 codes can identify inductions, and in fact, you can then pull out that subset of cases to again drill down. Further drill down, if you so choose, again, if you're involved in a quality improvement project and you want to look at what were some of the reasons for these C-sections to occur, you can look at them as mutually exclusive groups or not mutually exclusive. You can look at all of the coding for all of these complications. These complications, you can decide as a team what you want to look at. Some of the comorbidities, what were some of the drivers and at what rate for the cases in the numerator that ended up with a C-section. So again, lots of ways to drill down on the data because it is patient-specific, and you can sort the data by patient and then also by ICD-9 or ICD-10 codes. The next sample report is a maternal report on severe maternal morbidity. This was as a result of the article that came out by Dr. Callahan in 2012, where he looked at 12 years of administrative data and found that of the 25, 12 of the 25 had increased over this period, and that 75% of the cases had at least one more. The rate of cases with at least one morbidity increased by 75% between the periods that he was looking at. The greatest increases were in shock, blood transfusions, and acute renal failure. Many of you will recognize this metric. This is the one that's being used, as I said, by the Alliance for Innovation in Maternal Health, the AIM project. And this AIM project is focusing on 6 states and using the administrative data set. They're also inviting a group of systems to, in fact, participate in some of the AIM metrics, giving the outcome metrics to the AIM portal. Certainly there's more information on that on the ACOG website regarding this initiative that is funded by HRSA. So here is the universal outcome metrics for AIM. I'm just going to show you 2 here. One is the overall severe maternal morbidity rate, and then the second one is the severe maternal morbidity rate excluding cases that have transfusion. So again, this is looking at trend data. The AIM portal is going to be collecting trend information, historic baseline data for 2011 through 2014, and then quarterly from thereafter. So you can see providing hospitals their numerator and their denominator cases for this metric gives them an opportunity to at least have a visual verification that these numbers look reasonable to them. If they don't, again, the opportunity to drill down. We did calculate the outcome metric 2, which is without transfusion. So you can see that when we just pay attention to quarter 2 for 2015, this particular hospital had 20 cases in their numerator for quarter 2, but lost 17 of them, indicating that 17 of those cases they had only blood transfusion indicator, or had a blood transfusion indicator, so they were dropping out of that severe maternal mortality metric. The trend, this is just a trend of a subgroup of our hospitals over this period. You can see that similar to what Dr. Callahan and his co-authors found, there is a significant upward trend for these metrics. So again, important to focus on what's going on with severe maternal morbidity and certainly the value of the AIM project. The first neonatal project that we want, or the analysis that we want to talk about is this unexpected newborn complication. This is NQF number 716, healthy term newborn. As I mentioned, it was developed by California Maternal Quality Care Collaborative. It is a composite measure designed to identify the most important outcome for a family, a healthy term newborn. That's how it was endorsed originally by NQF. So it was initially designed to measure uncomplicated term infants who had no unexpected severe or moderate complications. So the rates were up in the neighborhood of 92 to 98%. What the developers found once they put it out there was feedback that it might be very valuable to reverse the numerator and identify only those healthy term newborns who had, in fact, an unexpected or moderate complication. So the denominator here is the singleton term infants being defined as greater than or equal to 37 weeks and greater than or equal to 2,500 grams without a congenital anomaly or fetal malformations not exposed to maternal drug use or selected maternal conditions. So the calculation that we're going to show you is the total unexpected newborn complications, and then they are subdivided between those that are severe and those that are moderate. The algorithm for these definitions is on, there is a link on the CMQCC website, so you can actually see the process, the algorithm and the flow of data to get to those that are severe versus those that are moderate. I mentioned APGAR here, and I mentioned that APGAR is very often difficult to get on the administrative data set. So one of the things that has occurred is hospitals have been asked to either submit APGAR on a separate file, as we've talked about, or if you're doing a quality improvement activity around this, certainly hospitals may be interested in doing that. That would be the only thing they would have to submit to look at this metric. The other option is to create a modified UNC, where you pull APGAR out of the definition so that you're looking at modified, and you can then calculate across all of the hospitals that are doing your QI project. This is a sample table again, the hospital, a peer group average we put here, and then the statewide average. And again, to the degree that you want to give lots of details in terms of what are the babies that are in the measure of population, which are the ones that have pre-existing conditions that are excluded, this just helps inform the hospital a little bit more about the number of cases that you found on the files for purposes of validation and accuracy. And then you get your final denominator and your total rate. And again, then you can subdivide that. The algorithm will do that for you. You can subdivide that between severe and moderate cases. Obviously, hospitals want to pay attention to those severe cases. Hopefully the numbers, the count of cases, this is 1 year's worth of data. So hopefully the count of cases are very low, but nevertheless, those are the ones where there may be situations where they are, there's exposure for medical malpractice claims. These are the ones that they want to get a handle on in terms of what occurred. Is there something that they can do within their institutions to improve the processes so these particular severe complications do not occur in the future. I mentioned here that if you have patient identifiers, then those hospitals can again drill down and look at those 104 cases or a sample of those cases to see what is happening, both on the quality of the data side, the quality of the coding, and then also the quality itself. Is there a real problem? This is just another way to present the data, peer group information. You can do it by peer group. You can subdivide your severe versus your moderate. It gives the peer groups an opportunity to look at the proportionality of their cases relative to a level of complication. You can do this by hospital. So this is another way to present this information. And then the last one I want to talk about is the neonatal abstinence syndrome. This is, as I said, a very serious problem that we have seen increasing over the last number of years. Many hospitals are seeing increases in cases with a range of acuity. The many newborn and special care nurseries are seeing an increase in volume and utilization. We do know that a number of the perinatal quality collaboratives are in fact focusing on neonatal abstinence syndrome as a critical QI initiative. So we want to show you a little bit about how we analyze the administrative data. Our sense is that it's not great. When we show this back to our members, they talk about a lot of reporting sensitivities, especially on the maternal side. So while it's not great, it should not be ignored. With dedicated effort to improve the identification and the coding, we think that it can certainly assist with sustainment of post-intervention monitoring. So here is, again, a display of the babies that have the neonatal abstinence syndrome. It is a DX code, so that's how you pull out the data. You can start with your total inborns, and then the percentage of cases that are coded with the nass code. Again, most of our hospitals reported that they felt as though this was fairly, on the baby side it was okay. On the maternal side, it was when you do a linked analysis, it was clearly underreported that the mother had an identified either dependency or abuse of opioids. Transfers in, these numbers are very small, but nevertheless, those regional centers that are getting transfers in, these babies are coming in to probably your special care nursery and are in fact going to be there for a fair amount of time. This is the trend for inborn nass identification over this period from 2009 to 2014. It's obviously a significant upward trend. And just to give you some of the drill down metrics that we found with this population, the average length of stay for babies with nass compared to the entire population is on average 20 days versus 4.2 days. 75% of the babies spend time in a special care nursery bed. The percentage of babies that are normal birth weight, for those with nass, it's just under 72% compared to just under 90% for babies without nass. Gestational age greater than or equal to 37 weeks on the nass side is about 54% of the babies, as opposed to just over 69%. If you do a linked mother-baby analysis, as we mentioned, the rate of mothers identified with drug dependence or non-drug dependent drug use does not match what we find in terms of the babies being identified. So there really is that issue of not coding the mom's record or not identifying these mothers when they come in, and it's a big concern. So with that, I am going to introduce Dr. Stat. Dr. Stat is going to talk about the enterprise-wide initiative for the Department for the Defense Health Agency that he led. Dr. Stat.
Great, thank you very much. I appreciate the kind introduction, and I'll explain a little bit of my role as far as I'm a maternal fetal medicine physician, and in the Air Force, one of us will be selected as the consultant, or basically the person in charge of kind of overseeing some of the day-to-day logistics operations, but also quality and safety for the Air Force. And in that position, I assumed it right. I'll have you go ahead and advance the next slide. Basically right after I assumed that position was when there was a flurry of activity or publicity, both primarily negative, from both the VA facilities and the federal healthcare system, and then also there was a set of articles from the New York Times that highlighted some of the concerns regarding patient safety and quality within the DoD, or the Department of Defense. Because of the publicity, there was the Secretary of Defense at that time, Chuck Hagel, had ordered a comprehensive review of all Department of Defense healthcare in response to some of the Times articles and also the concerns in the VA system. It was not limited to just obstetrics. However, obstetrics was a significant portion of the review and remains a significant cost in terms of money that we spend on malpractice claims is money that we don't have to put jet fuel in the fighters or put boots on the troops. So it's something that we see as a quality issue, but also realistically our defense budget is limited, and based on that limited dollars, the less we spend on paid claims, the more we can spend on warfighting missions. As far as the focus of the 90-day review was both access to care and as well as the safety and quality of the care, both within the military, and then we also rely on civilian healthcare providers or purchase care through the TRICARE health system. Through that 90-day review, there was a few areas that highlighted concerns. The most common complications were that seemed to be ahead or higher than our civilian averages was our obstetric hemorrhage rate, our shoulder dystocia, as well as our neonatal injury rates. And NPIC is what the collaboration of civilian hospitals that participate in NPIC is who we were being compared with. I'll go ahead and advance. Some of the challenges as far as clinically that are unique or at least fairly common in the military, both Air Force and the other services, is that we have a high turnover. 40% of our nurses at large centers have less than 3 years of experience. Most of the physicians we owe typically 4 years for medical school, and most physicians, about 70 or 80%, will separate after their first tour. So most of our physicians are younger and relatively fresh out of training. We also, it's not very common that we have senior nurses assuming or being clinically as active as, say, our civilian counterparts. Most mid to senior career nurses move on to assume leadership or administrative jobs, and not as many are actually involved in day-to-day patient care. Frequent moves, which kind of is part of the nature of being in the military. Every 3-4 years we're typically moving, which highlights kind of the importance of having standardized practices or standardized operating procedures, so that when you move from Germany to Japan or to Texas, that we do it similar and hopefully adopting best practices. Also varying institution types. We have some institutes that only deliver 10 deliveries a month, and we have some that do 300 a month, and it's a lot of it's based on location and training facilities or non-training facilities, and also some that are very, very remote. We talked a little bit, or I spoke just briefly about some of the waste and liability. Our operating instructions is efforts to try to reduce waste or trying to improve efficiency. We do have three electronic health system records. We have a system called CHCS that's back from the probably 80s. And then we have another system called Alta in the 90s that we do most of our outpatient documentation. And then we have Centris, which is a little bit newer in our inpatient record. So we have one of our challenges is multiple electronic health record systems, and that tends to create some difficulties making sure all of our records are accessible. And when capturing data, it's often hard to, if it's not put in well into the inpatient record, to capture some of the inpatient data fields if it was only collected on the outpatient record. We also have competing interests. A lot of us do have concerns or cares for patient safety and healthcare, but we also have other military duties that compete for our time and interests as well. Also, coding in the military, we rely on coding, but it's not, we do some direct billing to other health insurance companies, but it's probably not as sought after or as viewed as, I guess, important to say if your hospital is not going to receive dollars. Our dollars do come from TRICARE or directly from the chain of command of the military. We use a lot of our coding and our data either for patient safety or to help with manning, meaning how many doctors, nurses, techs do we get at a hospital, and they use our coded data to try to determine how busy we are and how many resources we actually need. You can go to the next slide. So because of that 90-day review and some of the problems that were highlighted, we developed the 2015 Perinatal Safety Initiative. I've introduced it to ACOG and got our physicians through the American College of OBGYN to adopt obstetric hemorrhage as our initiative, and then it was introduced through the Perinatal Advisory Group, kind of the tri-service overarching patient safety and quality group for the Department of Defense. Our initiative based on the administratively collected data was to try to improve obstetric hemorrhage was a main focus, and by doing that we adopted a standardized guideline protocols within every hospital that performs obstetrics. We also hosted about 18 different seminars online that was webcast to educate providers and staff, and I'll talk about the education of the coders as well in a moment. We also, part of this initiative was to ensure that every site was equipped for obstetric hemorrhage, having a hemorrhage kit, both medications as well as instruments available, so if they needed to do a hysterectomy or had a bad vaginal laceration, they had the equipment available. We also implemented active management of the third stage of labor and improvements in trying to estimate blood volume. And in terms of the administrative data, one significant change was ACOG, I think it was in 2014, released a set of standardized definitions trying to improve data purity or collection as far as what we call obstetric hemorrhage or postpartum hemorrhage. And previously, most centers used vaginal delivery with an estimated blood loss of 500 cc's, and a C-section was a liter. ACOG has introduced this definition of just calling it a liter, probably because of clinically it's rare that you would need to transfuse somebody with or have a severe maternal morbidity from a 500 cc blood loss, but the liter is probably more clinically significant. The other thing, part of our initiative is that we did standardized drills and required all providers and hospitals to perform obstetric hemorrhage, shoulder dystocia training and drills. And then the last part of the initiative was a study basically drilling down or looking at these outcomes for hemorrhage, shoulder dystocia, and birth trauma and trying to determine, do we really actually have a problem or is it just overzealous coders? And our hope was that we were doing everything awesome and that we could just blame it all on overcoding. But what we found was that with postpartum hemorrhage, it was about 8% overcoded, meaning we did have a significant problem. It wasn't, we were estimating that it was probably a higher percent that the coding would have said there was hemorrhage and there wasn't, but it was about an 8% overcode. Shoulder dystocia was almost identical as far as on the chart review for cases of shoulder dystocia. When they coded it shoulder dystocia, virtually 100% of the time there was a shoulder dystocia, so that was very accurate. Previously there had been efforts related to neonatal birth trauma, and unfortunately that was still a significant issue for our coding. About 10 years ago we had a similar deep dive into neonatal birth trauma, and they found only 25% of the time was the code correct. This time we've improved, but it's still approximately 48 to 50% of the time is that diagnosis actually true, meaning the other 50% was cases of caput or Mongolian spot or a case of Down syndrome was recorded as birth trauma. So there was still some improvement needed in that area. Because of that kind of discovery, there was a initiative to both train the coders both in the obstetric hemorrhage and the new definition or the new ACOG revitalized definition for obstetric hemorrhage, but also trying to nail down exactly what is neonatal injury and what things are not neonatal injury. So that has been done. The training of the coders have all been accomplished, but we're still at this point waiting to see if we'll probably want to go back and validate or verify that the educational efforts were productive and that we have improved data at some point. The part that is unique for us, a lot of our commanders aren't used to waiting several months for, if we launched the initiative in January of 2015, waiting 9 months to a year to see if it actually worked. They kind of want answers now. So because of the wanting to find out if all this standardization and extra training and checklists, if it actually has made an improvement, we asked or tasked all of our hospitals in the Air Force to manually collect or data abstract themselves anytime they had a shoulder dystocia or a obstetric hemorrhage or a severe maternal morbidity, that they had to directly report it to myself and our outcomes coordinator, Jamie. And then we, at that point, compared it to data from NPIC. Any hemorrhage or shoulder dystocia or neonatal injury, then also they had a peer review process on any of those adverse outcomes. I'll go to the next slide. So this is some of our real-time dashboard data that Jamie has been collecting and comparing it to NPIC data. There's lots of numbers on the screen, but just in general, everything so far that we've been collecting was very, very close as far as the integrity of our real-time data, and comparing it to NPIC data for the first quarter of 2015 looked very similar or very congruent, which is important because we'd love to not have to continue to collect the manually collected data if we have NPIC providing a similar service. Go ahead, next slide. And this is just the other outcomes. So again, we had shoulder dystocia, hemorrhage. We also had severe maternal morbidity. One thing to note, some of our facilities do not have a large delivery volume, so it's the confidence interval or the prediction of whether there has been a change or not with some of our training is very difficult to ascertain. If you're doing, say that hospital does 30 deliveries a month, you're going to need a lot more data points before you can truly say an initiative has worked. I'll go ahead to the next slide. So kind of to summarize our Air Force experience, so the strength of the administration data, one is that it's ease of collection. Janet and NPIC sends me a executive summary, and each of the hospitals within the Air Force get their own site-specific hospital. So that makes our jobs a lot easier because we all have other probably tasks or jobs to do. It also lets us compare how are we doing to other facilities, both within our service or across other services, and then also as a global, comparing it to other hospitals that subscribe to the NPIC service. Other strengths would include the accuracy of the coding. Like I mentioned, the shoulder dystocia was very, very accurate. Hemorrhage was pretty reasonably accurate. Neonatal injury was left something to be desired. So it does require a little bit of knowledge about each of these measures, how they're each getting collected, and then if there's more subjective, is it something the coder can come up with on their own, or is there pretty specific guidance on this, and then how strictly are they following to that guidance? The weaknesses, part of it's the time lag. Like I mentioned, our coding in the military may or may not be as timely or as viewed as a priority as other places. So it often takes anywhere from 6 months on the fast side to 9 months or a year on the slower end, depending on how quickly our coders turn in the data for us to see. So right now we're working, I think, on 2015, going on the third quarter, I think. Because of that time lag, it's sometimes difficult to make it actionable. So with that time lag, we can say, well, in 2015, we implemented all these measures, and we're just waiting to see. So it's not maybe as quick as we would like, but again, you have some trade-offs, and then the accuracy of the coding can be a strength and a weakness, and I think that just highlights probably what measure you're looking for and how that's being collected. I think that will summarize our Air Force experience.
Great. Thank you, Dr. Stat. Just briefly, a couple of other applications of the administrative data some of you may have used, that we've used in the past. You can certainly do a regionalization analysis. You can match the level of care of your facilities with the acuity of the population that's delivered at that facility. Look at neonatal and maternal transfer patterns, and also drill down by payer to determine the efficient use of resources. So that's another way that the state or the Perinatal Collaborative can look at the data statewide. We've done some linking with the birth certificate data, just looking at counts of cases, location of birth. perinatal complications. Certainly some of the variables on the birth certificate data can be merged into the source files, again, as we talked about. One of the dilemmas is whether or not you have access to the birth certificate if you've linked the birth certificate with the administrative data set, and then the timing of the birth certificate data. There are times when it's not as available, even though there's a lag with the administrative data. The 5 to 6 months after the close of the quarter can be a little bit more timely than some of the birth certificate data. So just to summarize and to move on to our Q&A section, I just want to summarize by saying that the administrative data, while we displayed, is not perfect, should not be overlooked as a tool to support your initiatives. All the perinatal events are captured in this data set. The core variables can be added to a primary data collection tool so that you're not re-abstracting date of birth or admit time or discharge time, those types of admit date, those types of things. And it can provide historic baseline rates so that you can know where your metrics were before you started your initiative, and then certainly give you quarterly or semi-annually ongoing updates to monitor pre and post quality improvement metrics and initiatives. So I want to thank you. With that, I'm going to turn it back over to Dr. Henderson.
Thank you so much, Janet. We appreciate this presentation. I'm going to ask the operator, she'll please open the line for questions. In the meantime, we will start to answer any chat questions. And I see here we have one question for you, Janet. And the question is from Susan Walker, and it says, "Hi, Janet. We understand that the National Coding Clearinghouse is aware of the problem with a lack of clear induction of labor ICD-10 code, and Joint Commission and others are working with them to correct this. Have you heard that the National Coding Clearinghouse will be taking up this issue soon to resolve this problem?"
It is my understanding from folks at ACOG that yes, this issue is before them, and so we're hoping that the next iteration will solve this problem. Stay tuned. Okay. The big problem, for those of you who may not realize, is that the ICD-10 induction coding does not allow you to discriminate if a woman had an augmentation. In the ICD-9 code, you could discriminate women who had an induction versus women who had augmentation. That's not clean. The coding for ICD-10 is not clean. So your numerator, when you're looking at cases that were induced, it's probably going to have some noise in it, in that it is going to have cases that also had augmentation.
Fantastic. I also would like to remind participants that the handouts with the slides were made available with your reminder email after registration for the webinar, and will also be made available again to registrants in the follow-up communication after the webinar. This presentation will also be archived on the CDC PQC webpage, and I'll give that web link again at the end of the presentation, but it's also on this last slide here. You can go to that website to see the archived presentation. Okay, the next chat question that we have here is, what issues were noted in use of the administrative data reflective of the AHRQ or IQI number 33 measure? Any trends in the accuracy of documentation versus coding accuracy would be helpful.
I guess I'm not quite sure. I think that, I'm not sure if I'm understanding the question. Certainly, as with anything, the IQI measure, when hospitals look at their IQI measure, it's important for them to look at their numerator, look at their denominator, and say, does this reflect what in fact is happening at their institution? The IQI trends, I'm not sure I'm answering your question. So if you can open your line and ask me articulate that for me a little bit better, that would be helpful. I think with anything, when you do trends and you've got large numbers of cases, the assumption is that for the few hospitals that are, or a large number of hospitals, that the few number of hospitals that may have a little bit of data that's not quite reflective of the numerator cases, that you still can get some fairly accurate trends with that IQI rate. I would say that primary C-sections, as we know, have in fact been going up over the years. They seem to be, from our perspective, they seem to be leveling off and will probably start coming down.
Fantastic. Do we have any questions on the line, on the phone line?
Okay, ladies and gentlemen, if you would like to register a question, please press the star followed by the 1 on your telephone keypad. If your question has been answered and you would like to withdraw your registration, please press the pound key. One moment, please. And at this time, I'm not showing any questions. Are there any further chat?
That was the last question. Okay. So at this time, I'd like to extend a special thanks to Janet Murray and Drs. Barton Statt and Marty McCaffrey for giving us such an excellent presentation on using administrative data for perinatal quality improvement initiatives. We'd also like to thank all of our participants for participating in this webinar and invite you to provide feedback about this presentation and this webinar series as a whole. We will be contacting you after the webinar for your input. We hope that our webpage and this webinar series will facilitate exchange of information and promote visibility of perinatal quality improvement activities throughout the country. You may also visit our webpage at www.cdc.gov/reproductive health/maternal infant health/PQC to learn more about CDC support of perinatal quality improvement collaboratives. Thank you again and have a nice afternoon.